Thank you so much for that introduction. I'm very excited to be here today to talk about contact dermatitis and give you guys an update for 2021. So as you mentioned, my name's Dathan Hamann. I went to U of A for med school and Ohio State for residency, and now I work at Contact Dermatitis Institute, where I do about 200 patch tests a year. I do work with Smart Practice, so that's my disclosure, but we won't be discussing any brands today. Contact dermatitis obviously has the two different components of being either irritant or allergic, and they can overlap. Irritant overall is more common, and I know when we're busy in our clinics diagnosing skin cancer, it's kind of easy to forget that contact dermatitis is a very, very common problem. It's more prevalent than melanoma, and it's more costly to society. It's a very expensive disease to take care of. And the quality of life impairment is actually really profound, particularly for patients who have chronic contact dermatitis on the hands or the face. This is the first case that we're going to use to discuss some learning points. And the first thing we're going to talk about is just patterns and morphology and distribution. So this is a 72-year-old male who presents with this itchy rash on the abdomen, but also intermittently on the arms for 2 years. I think many of us have a sense that this could be contact dermatitis. And if you thought to yourself, well, this could be a belt buckle sign or a sign of allergic contact dermatitis from nickel from a belt, you'd be right. And so this is his positive nickel DMG test. And this shows how his the skin lays right against his belt. Here's another case. This is a young college student who was a new patient for me, complained of itchy rash on the face for around 6 months. And if you think to yourself, oh, this is a perfect distribution for his eyeglasses, you'd be right. And this is another classic case of nickel allergic contact dermatitis from cutaneous exposure to a common daily device here. This is another great case. This is a 28-year-old African-American woman with chronic dermatitis in the ear and neck. And she had actually seen 2 other dermatologists who had told her that this was nickel dermatitis from jewelry. And if that's what you thought too, you would be right, but you'd also have missed the fact that she had many other positive patch tests that were relevant. So not only was she allergic to nickel, which was the case, but that clinical diagnosis missed that she was allergic to isothiazolinone, which was found in several of her products, fragrance, which was found in her products, and also ethylene diamine, which is found in her moisturizer. But also she's allergic to these rubber allergens, and it's interesting to see that she's wearing a mask with a rubber strap. Obviously that doesn't explain this, but her overall ear itching, I have no doubt, was partially related to this. So I know we see in the textbook, like this is a patient of mine, but the textbook kind of likes to show these very classic, geometric, interesting distributions. And so good dermatologists really should be familiar with these, but they shouldn't rely on them alone. Because, for example, this patient, their important, relevant allergic contact dermatitis diagnoses were missed because of reliance on classic features. So the first learning point really is that, if you see a patient with a classic distribution, then yeah, you should think of contact dermatitis. But if it doesn't meet that and they continue to struggle over time, many of my patients do not have geometric features or classic distributions. And so, making a clinical diagnosis of contact dermatitis is something we do often, but we should be aware that we can miss these more difficult cases if we rely on that alone. So that's our first learning point here today. This is the second case to illustrate another interesting learning point. And this is facial dermatitis in a 65-year-old woman who was diagnosed with adult onset atopic dermatitis and also with perioral dermatitis. And she was allergic to triamcinolone. And with avoidance, she did really well in just a few weeks. This is another case that I saw over the last few months of a gentleman who had a distant history of motorcycle accident, trauma with a skin graft, and had been diagnosed with venous stasis dermatitis. And he probably does have an element of that, but on patch testing we found that he was allergic to several of his wound care products like bacitracin and polymyxin. He also was allergic to Carbamix, which carbamates are found in the rubber ACE wraps that he used for wound care, and he was also allergic to sorbic acid, which was found in his triamcinolone prescribed by his dermatologist. Another interesting case recently of iatrogenic dermatitis. I think this was a 55-year-old gentleman who had been using Eucrisa for the better part of a couple years, allergic to both clobetasol and Eucrisa. So the second learning point really is that we need to be aggressive about ruling out iatrogenic contact dermatitis. So when you have, if you're not getting every once in a while a patch-tested patient that has this, you may be missing it. This is another gentleman who was a roofer, and he presented with an eruption, and this is looks a lot like lichen amyloidosis or lichen planus variant. and this is a lichenoid contact dermatitis. We see a lot of different types of non-eczematous allergic contact, particularly from acrylates, rubber allergens, and from PPD. So don't forget that. Even on the patch test itself, you can see here this dioscopy shows that this is a balsam, is a very classic blanching reaction. But this one here is purpuric. So the absence of eczematous features doesn't mean that contact dermatitis could not be contributing to your patient's problems. So the third learning point is that allergic contact may have non-eczematous features. When we talk about how we decide who needs a patch test, I hear a few things that are common misconceptions. And the first is that I've sent quite a few patients for patch testing and they're all negative, so I should send fewer. Or I hear the opposite. Everyone that I send is positive, so I must be referring the right types of people. When we talk about who should get a patch test, if we referred everyone with any rash, we'd never miss anything. But if we referred only those with the most classic presentations, we would miss quite a few. And so we're trying to find an area where about half of our patients are patch test negative and half are patch test positive. So when we consider who needs a patch test, we should patch test anyone with chronic hand or face dermatitis, really high morbidity dermatitis, or patients before you start systemic therapies. It's one of the greatest abuse of patch testing is really underutilization, failure to use the test. And most experts say that if about half of your patch test referrals have positive tests, you're doing a good job. So our final case here, this is a 66-year-old gentleman who had 3 years of rash, chronic generalized rash on the trunk primarily, and he was reportedly patch test negative several years before, but those records were unavailable. And he was referred by a colleague of mine for patch testing prior to starting Dupixent. And he was given the diagnosis of adult onset atopic dermatitis. And he was really broken out, tough to test. But you can see that he was allergic to tixacordol. So he was clear in just 6 weeks with avoidance of his triamcinolone and his other topical steroids. We switched to class C steroids. So, when we have these really difficult patients that may or may not be atopics and they have any atypical features, that's important that we do patch testing before starting systemic immunotherapy or immunomodulatory therapy. So in fact, in a recent study, people who had atopic dermatitis who had failed or had some recalcitrant disease, over 90% of patients in this cohort here had undiagnosed contact dermatitis. So that would be our last learning points for today. Thank you so much for your attention, and it was a pleasure being here.